This podcast is sponsored by Eli Lilly.
Weight is really determined by a certain part of our brain called the hypothalamus that has we call it a set point. And that is genetically determined, but there are also other factors like stress levels, the amount of sleep that you're getting, certain medications that could affect that set point as well. We now know that patients with psoriasis have about a 50% higher risk of having cardiovascular disease. Patients who have higher BMIs tend to have more severe disease. And what higher BMI, it's generally harder to treat.
Welcome to Derm-It Trotter. Don't swear about skincare, where host Dr. Shannon C. Trotter, a board-certified dermatologist, sits down with fellow dermatologists and skincare experts to separate fact from fiction and simplify skincare. Let's get started.
Welcome to the Derm-It Trotter Don't Swear About Skincare podcast. I'm with Dr. James Song. He's a board-certified dermatologist and director of clinical research and serves as the chief medical officer for Frontier Dermatology. And we're here today to talk about psoriasis and obesity and the connection that exists between the two. I think that a lot of people, you're going to be shocked about sort of what we've learned and where we can go from here. But I want to welcome you to the podcast. It's great to have you on here, Dr. Song.
Shannon, thank you so much for having me. I've been following you for quite some time now, and I always was looking forward to the opportunity to be a part of this. So I thank you for making one of my dreams come true.
Well, always happy to please. And we're excited to have you here too, because we know psoriasis is a passion of yours and definitely very engaged, obviously, in research and treating patients and even at the foundation level. So I wanted to tackle, this idea of psoriasis and obesity, because I think a lot of people, really aren't familiar with the connection. They don't realize that, that there is a connection in the first place. And, just talking about when we think about ourselves, all of us look at ourselves and probably complain or think, gosh, I could lose a few pounds or I'm a little overweight. And not even knowing that when we look at fat in the body, that there are different types of fat. So I wanted to talk a little bit more about that, see if we can walk our audience through those different types and do they have a real role in the body too? Because I think a lot of people just think that's just hanging out. It's not doing much of anything.
Yeah. It's a great question, Shannon. Yeah, I think when most people think about fat, they think about it like stuffing, right? It's just excess calories that you're not burning, so you're kind of just sitting there. That's not entirely true, though. We do know there's several different types of fat depending on where that fat is on the body. They have several different functions. It could be actually beneficial to a certain degree, but also harmful. And we'll kind of just touch a little bit on that. I think for most people, when they think fat, they think about the skin that you could pinch, right? And that's what we call subcutaneous fat. And for the most part, that's pretty harmless. It doesn't really do anything bad. It's really the fat that's around our belly and our kind of, we call it our viscera. We call that visceral fat. That's the dangerous fat. That's the one that we know is kind of like a chemical factory that is just pouring out what we call cytokines. We'll get into that later. These are kind of messages to the rest of our immune system to kind of overreact. But that's really the main reservoir of those kind of harmful cytokines that contribute to a lot of the diseases that we treat in dermatology. And just to kind of round that out, Shannon, we have what we call brown fat. That is what we see more in infants, where you actually burn those calories to generate heat and then kind of goes away as we get older. But interestingly, for people who exercise and do like cold plunges, that's kind of, all the craze now. There is some data to suggest it increases the brown fat, but as we get older and gain more fat, that good brown fat actually goes down as well. So I think it's just important that not all fat is created equal, but also when you look at somebody of different ethnic racial backgrounds, Asians, I'm going to use an example. A lot of us look thin. We have, low subcutaneous fat, but actually we have a good amount of visceral fat. And that's really the fat that's bad for you.
Very interesting, because I think, when people think of fat, they just think of fat, right? And like you mentioned, it's just sort of hanging out and not really active in the body. And what we've learned over time, as you mentioned, with the different roles, that lovely pinchable fat, which I can get enough on my waist here, that keeps us warm and helps with that temperature regulation. And then having, a role of the body where visceral fat serves a little bit of a role that's in a positive way, but obviously too much of it, not so great for us. Let's talk about where that kind of goes wrong and sort of what's happening with fat, where again, I think people think it's just kind of dormant, it's hanging out. How is fat really metabolically active? Like, what is it doing just hanging out in the body?
Yeah, I think it's best to think about fat or what we call adipocytes as a biologically active like endocrine system. I mean, that's really what it is. It's an organ that
Hmm.
spews out various different messages to the rest of our body. On the one hand, fat is good because there are certain hormones we call leptin that once you eat, it tells you that you are full, right? So it's a satiety signal, but it also is a very pro-inflammatory signal as well. It actually increases certain cytokines like Th17, for example. But in addition to that, there are other pro-inflammatory cytokines like TNF alpha, IL-1, IL-6. I mentioned Th17. And if they sound familiar, they should, because these are the same cytokines that cause a lot of the autoimmune disorders that we treat, whether that's psoriasis and psoriatic arthritis. And so it's not a surprise that if you have this major source of inflammation, patients who are obese tend to be at higher risk of developing certain conditions such as psoriasis and psoriatic arthritis.
Wow, and that's, I think where it gets a little confusing, right, for people to understand that it's truly, like you said, a part of that endocrine system really being metabolically active and contributing potentially to inflammation in different disease states like psoriasis. When we think about, somebody who is overweight or obese, one of the things that always, bothers me is we tend to be judgmental, right? We automatically look at these people and think, oh, it's a lack of willpower. You're just not able to control yourself if you've got a bag of Doritos in front of you. And I really try to get people to understand, it's really not that simple. I mean, we all have our cravings, right? We love our midnight runs. Some people do that to Taco Bell. You see the line out the door, or somebody has, their chips they love, or they may not exercise as much as they want to or need to. But, I think the idea of obesity, what we need to change in our mindset is this is really more of a complex disease state. When we're overweight or we have excess fat, this is something that it's multifactorial and a lot of things contribute to that. How do you walk patients through understanding that this isn't just a lack of willpower, but sort of a combination of several complex factors that actually contribute to them being overweight or obese?
It's such an important point, Shannon, because I think until we start to think differently and frame it differently, we're not going to make any progress in this area. To your point, a lot of times patients are told it's a character flaw. They don't have
Mhm.
willpower, right? And they need to try harder and take care of themselves, and this all goes away. And we know that so much of this is genetic. We know that weight is really determined by a certain part of our brain called the hypothalamus that has we call it a set point, and that is genetically determined. But there are also other factors like stress levels, the amount of sleep that you're getting, certain medications that could affect that set point as well. But you could try your darn best to eat better, exercise, and what does your set point do? It tells you to be even more hungry. It tells your metabolism to slow down, right? Because it's like a thermostat. So
Mhm.
until we could adjust that set point, it's very, very difficult. And this isn't that different than someone with high blood pressure, right? If someone has blood pressure problems, you'd be like, hey, diet and exercise first. And if that doesn't work, then we're going to put you on medical therapy. And we're not going to make people feel bad about not doing enough diet and exercise to get your blood pressure under control. Why are we thinking about obesity any differently? I mean, it's a disease. And so we should be thinking about it in the same way of hypertension, hyperlipidemia, and diabetes. And that's why we call this kind of metabolic syndrome.
Really good point, because I think for a lot of patients, they put it on themselves. There's a lot of shame, embarrassment. And I think
Yeah.
even as, dermatologists, we can kind of admit to ourselves, I think sometimes, you have a little, bias sometimes, or when you see people and just really changing that set point and making us all realize, like you said, this is a disease like anything else. Why would we treat it any differently? Unfortunately, I think a lot of, those cultural norms kind of infiltrate into our thoughts, or, our ideas of what we were sort of told about, being overweight or obese, truly what it is, when we now understand, it's much more complex. I think getting over that hurdle, as the dermatologist or healthcare provider, and then also for patients to embrace that and understand that we are here to help, and beyond, yes, diet and exercise are essential, but there are ways to kind of build on that and
Yep.
really help them through that process, because it's going to impact their overall health. But I know from our standpoint, we're also obviously looking at the skin health. And in
Mhm.
specifically, in certain disease states, we know hidradenitis suppurativa, we know psoriasis, like these are impacted. In particular, psoriasis, I think is a lot of interest to our listeners that have reached out and said, we see this craze about talking about now weight and the psoriasis connection. So I wanted to go back and kind of visit your thoughts on this connection, sort of what you've seen over your career and in the latest, data coming out, and how we
Yeah.
understand that connection to actually really exist between the two.
Yeah, yeah. So as we said, we know psoriasis, or excuse me, obesity can increase one's risk of psoriasis. There's no question, and the same is true for psoriatic arthritis. And that connection or relationship may be even stronger with the latter. A lot of times we have a hard time separating out: is it the actual obesity that leads to psoriasis, or are there other confounding factors? But there's been actually a number of really well done, what we call Mendelian randomization studies, where you look at genetic variants that predispose somebody to obesity. And then you follow those people who have those genes and see who gets psoriasis. And that really controls for a lot of the confounding variables. You're really just looking at genetics here. And we're seeing up to a twofold higher risk of developing psoriasis or psoriatic arthritis if you are obese, for many of the reasons that we talked about. You have this big chemical factory that's pouring out these cytokines that we know can cause psoriasis and psoriatic arthritis. Anecdotally, what we've seen, at least in case reports and now larger case series, is that patients who have both psoriasis and type 2 diabetes, they go on a treatment for their diabetes, right? Specifically, we call it a GLP-1 receptor agonist, or a GLP-1 with a GIP, so it's a kind of a combo therapy. And without any psoriasis therapies at all, not only do their weight go down, not only does their diabetes improve, but their skin clears as well. And I think that was the first signal that there is something here to it. Now, the question, Shannon, is it the weight loss itself that actually leads to the psoriasis improvement? Because we've seen other studies where hypocaloric diets, bariatric surgery, or any other type of lifestyle intervention that reduces the weight can also indirectly improve psoriasis. So there probably is something to that. But what is interesting is that these patients are also clearing their skin even before they have any meaningful change in their weight, which makes us wonder, is there a direct effect with these weight loss medications that we see on the inflammatory component of psoriasis? And the answer to that probably is yes. And we have some what we call in vitro data, which isn't human data, but some of the in vitro data suggests that GLP-1s can actually modulate the immune system in such a way where it decreases cytokine signaling, immune cell trafficking. Some of those cytokines that we talked about before, like TNF and IL-17, they come down even independent of weight. So I think it's a really kind of fascinating and exciting area of research, how we can use weight loss medications that improve inflammatory disorders independently of the weight loss.
So if I was your psoriasis patient and came to you and I, saw that your little blurb, maybe on my Yahoo News and, that this is happening and I have psoriasis, how would you approach that with me if, I am overweight or obese? I've started to say, hey, Dr. Song, I want to go on a GLP-1. Is it that simple or is it a more complex conversation to talk about?
Yeah, I think as with all things, benefit versus risk, right? And I think people often focus so much on the risks, which is understandable, right? Safety is important, but we don't talk enough about not treating or under treating a disease and what are the downstream consequences of having not just psoriasis, but also the comorbidities associated with psoriasis as well. We now know that patients with psoriasis have about a 50% higher risk of having cardiovascular disease. Okay, and that's independent of traditional risk factors. So you take the hypertension, the lipids, the cholesterol, and the weight out, they still have about a 50% higher risk. And this leads to about a 5-year decrease in life expectancy. So I start with that. And while the weight loss is great and all, and it's going to help, I think, with not just with the weight, the diabetes, and the psoriasis, we now have data. It's actually on the label, Shannon, for several of our semaglutides, liraglutides, that it actually lowers MACE risk. I mean, that's on the label. It decreases heart attacks, strokes, all-cause cardiovascular death. I just got back from the EADV in Paris, and there was a very, very powerful podium presentation about people who use GLP-1s and who have psoriasis versus non-GLP-1 diabetes medications. Not only do they live longer, their risk of anxiety and depression goes down, their use of substances like illicit drugs and alcohol go significantly down too. So I try to bring in all the positive benefits, even outside of the skin, of using these types of medications. So absolutely, if you qualify for a GLP-1, right, you've done all the lifestyle changes that we talked about, which isn't easy, but you've done it, and you meet the eligibility criteria, which is fairly simple. It's you have a BMI of 30 or greater, or a BMI of 27 or greater, but you have one weight related comorbidity. So blood pressure, diabetes, cholesterol, sleep apnea, cardiovascular disease. Then yes, absolutely, this is something that we bring up. The question though, Shannon, is you have a 5 to 10 minute visit for these patients. We don't have teams of biologic coordinators that can do these medications or push these medicines for us. How do we have the time and the resources to do all these things? And I would be lying if I said I have it figured out.
Hmm.
I do this enough, and I'm fortunate enough to be in a bigger private practice where we have those means to do that. But I certainly want to. I empathize with our colleagues who may push back and say, "I just don't have the time or resources to do that." At least what I would say to those people would be that at least have the conversation, make that connection, and then if a patient is interested, at least try to refer them to someone that actually can help get them on these types of medications.
Well, very powerful what you mentioned about in the label, because I think that would shock, a lot of our listeners out there that might be on one of these medications and not even know the benefit, regardless if they have psoriasis or another condition or not. And even some of our healthcare providers on the power that I can offer for patients and being potentially cardioprotective. That's pretty amazing. And
Yeah,
for dermatology, you're right. It is tough, in the environment that we work in, but also the opportunity to collaborate with our colleagues in the primary care space to make that happen for patients. Just knowing there's that benefit, I think there's an opportunity there, to offer to patients. Do you feel like, based on maybe what we know with some of that data, or what we're looking at probably going forward and what's in clinical trials, do you think for management of psoriasis that it's sort of a, monotherapy where you just go on a
yeah,
GLP-1 or a GIP-1, or maybe you're going to actually, combine it? Or what are your thoughts
yeah.
on might be the ideal strategy on what we might do?
We do have one study that is ongoing, actually two in parallel. It's called the Together Psoriasis or the Together Psoriatic Arthritis studies. And this is looking at ixekizumab, which is an IL-17A inhibitor, very effective for psoriasis. And you are combining that with tirzepatide, which is a dual GLP-1 and GIP inhibitor, versus those who just get ixekizumab alone. So you want to see, is there an additive benefit or a synergistic benefit of combining these therapies? We should be getting the top line data here probably sometime in later 2026, I believe. But that is the way that it is being studied. And I do believe that that's the best way, is to use them as combination or adjunctive therapy versus just monotherapy alone. Although I will say, Shannon, if you have very mild psoriasis, so just a couple little plaques here and there, and you have the comorbidities that qualify you for getting onto one of these medicines, you may be able to just go on monotherapy alone, right? And
Hmm.
then one thing, I didn't mention here, I think it's important, is that patients who have higher BMIs tend to have more severe disease. And what higher BMI, it's generally harder to treat. Even though we have really effective medicines now in psoriasis, the heavier you are, the medicines just don't work quite as well. We see a much bigger drop off with our older medicines like TNF inhibitors, but even our newer ones like IL-17 or IL-23 inhibitors, you do start to see a drop off in patients who get beyond 250 pounds, which is why some of these medicines are weight based. And I think those medicines might be better for the heavier patients because standard dosing doesn't work for everybody. But the biggest kind of, I think, data point here that's important is that when you looked at ixekizumab in their phase 3 studies, Shannon, and you looked at PASI 100, that's 100% clear. The difference of being less than 25 BMI versus 40 BMI or greater was profound. We're talking about a 20% plus difference
Wow.
in the likelihood of getting to
Mhm.
100% clear. So about a twofold difference. And this was the same with psoriatic arthritis. When we look at minimal disease activity, which is a very high bar, very low levels of disease activity in your joints and your skin, you're still twice as likely to get to that high bar if you were under a BMI of 25 versus over 40. So that makes a lot of sense then why using a GLP-1 in addition to ixekizumab may provide additional benefits for these patients.
I know you and I are familiar with BMI. Do you mind commenting on BMI, how
Yeah,
that's sort of calculated? Because for some of our listeners,
sure.
I think I've heard of that, but I really don't know what it means. But I've been told I have a very high
Yeah.
one. And
Yep. So BMI is just one way of measuring weight, right? Or obesity. It's not perfect. So the way we calculate it, we take your weight in kilograms and divide it by your height in meters squared, and you get a number. Um, the number that's over, let's say a 25 might mean that you're overweight. A number over 30 means you're obese. Over 40, you're severely obese. That's a really kind of, it's an imperfect way of measuring fat, but it's kind of probably the simplest way to doing it. We know that there are people out there that who are very, very muscular and athletic, and they can have very high BMIs, right? You look at The Rock, right? Dwayne Johnson,
Yeah.
guy is ripped and shredded. I think he's like 6'2" or 6'3" and weighs like upper 200 pounds. You do the math, he is severely obese, right?
Right.
No one would say that to him, right? Not in front of his face, but even still objectively, he is very, very good shape, very muscular. But it just goes to show that BMI actually overestimates the score in muscular individuals. And there are a lot of other examples of that as well. There's other ways to measure body fat, though. There's DEXA scans, which are like X-rays that look at the density of bone, muscle, fat. There's impedance tests where you could just hold on to something. It sends electrical currents. You could do caliper studies. So there's a lot of different ways to do it. BMI is just kind of our quick and dirty way of measuring the fat levels, which, again, is not perfect.
But you're right, it gives us a really good gauge, at least to work from now. And maybe we'll improve upon that, as a metric as we kind of go forward and classify, patients a little bit better, regarding their weight. But you're right, it's the best thing we've kind of got now, although imperfect. So if somebody's out there listening, in the last few minutes we're having, they're thinking, you've kind of sold me on this. I've got psoriasis, I'm worried about my risk factors. They may or may not, have diabetes already, or one of the other, risk factors or comorbidities like high blood pressure or cholesterol. What would you say to them as potentially, a reason maybe you wouldn't consider doing it? And then if it was, meant for them, how would you move forward with that?
Yeah. The biggest barrier, Shannon, is going to be cost and access. There's no question these are expensive medications, but I would argue that the cost of not treating is even more expensive, right? Because we're just delaying the inevitable, and having to get an open heart surgery or some other major medical intervention will cost a lot more money. But that's the main barrier, right? And then the natural question that comes up is, if I can get insurance to pay for it, what about compounded medications, right? And I think this is a conversation for another day, but you really have to be careful of what you're getting with compounded medications. I understand it's cheaper, but you don't always know what you're getting there. If you have diabetes or obesity, and you as an office, as a dermatology practitioner, just don't know how to do it or don't have the means to do it, at least refer them to somebody, whether it's a primary care doctor or an endocrinologist that can really do the heavy work to get this approved, because truly these are life-changing drugs. And I think that we are doing a disservice to our patients if we don't at least bring it up to them.
And I think too, patients out there now are going to be asking about it, listening to this, just seeing that there's value, and, looking at, being overweight or obese is more than we talked about, that lack of willpower. Hopefully for, the dermatologists and providers listening out there, that they're thinking, what, I should probably be approaching my patient maybe a bit more holistically. I think that's a shift we're going to see in dermatology as a whole, as we look at a lot of our skin conditions as, more so systemic inflammation. We've known this for years, but now that we have opportunities to treat it, I think it's going to shift. It's interesting. I think, we used to have the internal med and then derm model. I don't see us going back to that paradigm for training, but boy, is it going to be integrated more into how we manage patients. Yes.
Yes.
Well, I want to thank you so much for coming on and kind of going over this. I know it's succinct, but this gives people really a taste, I think, for our listeners, of understanding, that how complex, obesity can be, and the link, to psoriasis and other inflammatory disease and skin that we'll obviously touch upon in the future. But thank you so much for sharing your expertise with us today.
Shannon, it's my pleasure. Thank you for having me.
For our listeners that want to track you down online, how can they find you?
My Instagram handle is E as in Edward, J as in James, and song, like singing a song, 812. And then it's the same one on LinkedIn. So I try to be active, not nearly as active as you, Shannon. I need to up my social media game, but yes, you can find me on there.
Well, thank you for sharing. I'm sure some people will check it out. And stay tuned for the next episode of Derm-It Trotter, Don't Swear About Skincare.
Thanks for listening to Derm-It Trotter. For more about skincare, visit dermittrotter.com. Don't forget to subscribe, leave a review, and share this podcast with anyone who needs a little skincare sanity. Until next time, stay skin smart.